Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto. I am the host of the Medical Society's podcast, Delaware Healthcare Reality. This is Health Literacy Month, and we have a special guest who knows a lot about it, and that's Amanda Joie. Amanda Joie is a nursing professional development specialist for the patient and family health education team at ChristianaCare. She has over 10 years' experience with the ChristianaCare organization. Amanda began her career in direct patient care. She received her bachelor's degree in the science of nursing from Rutgers University and her master's degree in nursing leadership from Wilmington University. Amanda is board certified as a cardiac vascular nurse. She holds the Institute of Healthcare Advancement's Health Literacy Specialist Certificate. She works on the development of all members of the healthcare team to provide effective, efficient, and equitable patient education. Welcome, Amanda.
Thanks for having me.
Good to have you here. You know, it is said that only 12% of U.S. adults are highly proficient when it comes to health literacy, which is the capacity to understand medical information. Much of my comments are extracted from an AMA article by Laura Killian and Mary Coletti. Tell me a little bit about it.
Health literacy?
Yes.
Sure. So I love that quote, that statistics. Basically, when I'm talking about health literacy, there's really two parts to that. So it's a personal health literacy, a person's ability to obtain, process, and understand the health information we share, and also organizational health literacy. So that's a system's, what they're putting in place to help patients get there and understand their health. 12% is really interesting to me. So one thing we know is that 9 out of 10 adults have trouble understanding their health information, which falls pretty good into line with that. And it's kind of an epidemic of misunderstanding for patients. There's a real, there's like a whole effect that this has. I leave my office visit, I don't understand what I'm supposed to do, and at the end of the day, if I don't know what I'm supposed to do or how to do it, it ends in patient harm. So that's really what my role is, and what I do is working towards helping people find out how to get their patients to understand what's going on with their health, how to help them understand what they're supposed to do. Because right now, if our patients don't understand, they don't even have the opportunity to be successful.
Do you approach them at the hospital level when they've been talked to by their doctor and say, I'll explain it now?
So I don't get to have the one-on-one interaction with patients that I used to when I was working in bedside nursing. So I really spend more of my time helping develop the staff that has that one-on-one care and give them the tools and resources to be effective with their teaching, kind of going over best practices of what they can do to help their patients understand. Now, we do sometimes do focus groups with patients to try to understand how they relate to information or what works best, and that's a best practice. But most of the work I do is actually helping doctors, nurses, people who work in social work, help them explain things in a more simple way, and then use teachback, I'm not sure if you've heard of that, to actually find out if they did a good job of explaining.
Got it. Sounds good. We have to educate our patients in this regard, because if they don't understand what's wrong and what we're going to do about it, things can go bad, as you mentioned. I guess we patient providers do not come down to the level of the average patient when it becomes necessary to explain their medical condition. The patient may give us a blank stare or a nod of understanding, but have no idea what we've just said. And this med speak can shut down effective communication with patients. For example, Mrs. Jones, you have a thrombosis of the iliofemoral artery. Mrs. Jones looks at me and shakes her head. Walk out of the room and she'll say, what did I just hear? Instead of saying, like, well, you have a blood clot. They kind of know what that means. In your arteries going to your leg. And that she may understand. In my office, I will provide pictures. I have a little educational picture thing that shows all parts of the body and what we're talking about. And I'll put it to the patient so they fully understand what's going on. They appreciate it immensely because they really don't know what's going on. And we, in medical terminology, kind of leave them blank. Can watering down the medical terms improve the decision-making between the healthcare provider and the patient. I sort of touched on that, but why don't you take it from there?
Yeah, absolutely. And I think what you'll find is that we as care providers have forgotten what we didn't know before we went into these fields. And sometimes it's really hard for us to remember what's medical jargon and what's plain language for the everyday person. So I really like to talk kind of about my personal experiences.
Go right ahead.
I had my parents didn't really go to school. My mom didn't graduate from high school, but they are everyday Americans. So they're our community. These are the people we serve, and they're really lucky because their daughter's a nurse. So they have me as an advocate. But if they didn't, I really question what would happen to them. So one example of this is when I was on my honeymoon. I got a call from my brother that my mom was in the hospital. He didn't really understand what was going on because he didn't think she understood. She didn't want to call me because I was on vacation. So I called her, and she tells me...
vacation. You were on your honeymoon.
I was on my honeymoon. But, I called her, and I asked her, what's going on. She was kind of tearful. She told me that she had a hole in her heart. She wasn't doing too good. She doesn't really, the doctors came in there. It seems pretty bad. She's in the ICU. And I said, okay, I want you to do me a favor, and I want you to use your call bell and ask the nurse when she has 5 minutes to give me a call. Because it wasn't really making sense, and I find that happens 99% of the time when someone I know calls me and asks me for my advice. I don't have the information I need to give them the advice they need. So the nurse called me, and what really happened was my mom had a pulmonary embolism, and they had ruled out cardiac tamponade.
Okay.
And she had really hung on to cardiac tamponade and pulmonary embolism, and they were explaining things, but she was so stuck on those big words she didn't understand. She made an inference from cardiac tamponade, and she truly believed that she had a hole in her heart. And, had no idea that she had a blood clot. No idea whatsoever. She had already been in the hospital for over a day before I was notified.
She was probably scared to death.
Right. And so is it a serious diagnosis? Of course. But had someone taken the time to not just say, hey, do you understand? Had someone taken the time to explain it first, simply, and then ask her to explain what she understands about her condition, they would have known right away she did not understand. And without me, she never would have understood. And I think it just goes to show how often people are shaking their head yes.
Nodding.
Because she wouldn't want you to think she was stupid.
Right.
She really has a lot of pride, and she's not. My parents aren't, you know what I mean? So I think that we have to remember that, everyday people didn't go to medical school.
Correct. I often see patients nod their head, like you said, or give you that blank stare like they understand what you're saying. I have very few of them say, what did you mean? If they do, I go into watering it down as best I can for their understanding. Do you recommend that providers make use of the Health Literacy Universal Precautions Kit, published by the U.S. Agency for Healthcare Research and Quality, to improve patient safety and healthcare outcomes by using terms that will be better understood by the patient? So the takeaway here is avoid med speak. I teach a lot of students in medicine as they're coming up. And I tell them, the patient will tell you what's wrong, and we just put a big name to it. They say, what's wrong? I can't breathe. Well, is it asthma? Or, everybody knows asthma. Is it a pulmonary embolism? What's that? And so I try to tell the students, talk to them at their level, so that they fully understand what they have. And they can make better decisions and also follow directions that you're going to give them. Because if they don't know what they have, they get this medication or they get directions on other things to do to improve their condition, they don't do them because they have no idea what they're doing them for.
Right.
Okay. Do you recommend about that kit that I talked about?
Absolutely. It's like a Bible for me in my work.
Okay.
What I would say is you really want to meet people where they are, and what we know is that most people are going to have trouble understanding the information. So starting by, simplifying the terms that we use, avoiding acronyms or medical jargon. There will be times when you need to use a medical word. Maybe it's a diagnosis. Explain what that means when you have to do that. And then following it up by asking that patient to either explain it back in their own words or to show you what it is that you just taught them if you're teaching them maybe how to take a medicine, for example. And that is your opportunity right there, that teach back moment, because you may do everything very simply from your point of view. But if the patient didn't understand it, then we didn't do a good job of teaching, and we need to teach it for them a different way. If we don't do that, the only time we really find out when there's been a miscommunication is when there's been either an error or patient harm.
Gotcha. I'll just bring up a particular thing that happened to me just recently. You're a cardiac nurse, so you know what a TAVR is, right?
Mm-hmm.
Well, I had a patient who had an aortic stenosis severe and was a candidate for a TAVR. She talked to the cardiologist, and he said, we have to replace your valve, and it's called a TAVR. Well, she didn't understand it fully, came back to me, who's on the same floor as the cardiologist, and said, he's going to replace my heart valve in a tavern? I said, no. He's going to do the procedure, and I explained transcatheter valvular replacement. And I said, it's going to go through your... Didn't he explain it? No, he didn't. He just said, I'll see you at the hospital. So I explained it to her, and she was quite comfortable afterwards. She said, oh, they could do that without having to open up my chest and all. I said, that's the benefit of modern medicine. And she kind of understood it then. And I showed her pictures of how it was going to happen. But I'd like to know what tavern she was going to get to have it done. I'd go have a beer with her. Okay, now, I'd like you to comment on how do we approach patients and make them feel comfortable and make them understand what's going on.
Yeah, so first and foremost, we need to establish trust with our patients. And there's a lot of reasons why patients don't always trust the healthcare system. So the easiest thing you can do is acknowledge the patient and greet them warmly. Use a positive tone and attitude when you're speaking with your patients. Make eye contact. This is the time to look away from your computer, not be answering the pages on the phone. If you can silence your phone for an encounter, that would be amazing. Patients definitely recognize that and appreciate it. Listen to the patient when they're ready to speak and when they have questions, and listen with empathy. Avoid medical jargon, which I know we talked a lot about. Trying to use plain language. Again, making sure that we're using the language that we think the person that we love or know that doesn't work in healthcare would know. Right? Think of it that way.
Right.
Speak slowly. Take your time. If we give the message at a rate a person can't process, the message is lost and it was a waste of everyone's time, really. If you have resources available to you in your organization, pictures, videos, those things can be really helpful for different people. Everybody learns differently, so having different ways to show something can be very, very helpful. And also having something that they can go home with, that they can leave with and refer back to, that's written, or a video that's in like an understandable format is very helpful. Make sure you give opportunity for questions. And I really like to hone in on, don't ask them, do you have questions? They're all going to say no. So using open-ended questions like, what questions do you have for me? What do you want to know more about?
Good point.
What do you feel like you don't have enough information on? Right? Those kinds of things really make people feel a little bit more comfortable asking those questions. And then confirm their understanding by asking them to, again, explain it back, right? Or repeat it back. Or to show you. If I'm sending someone home new with, an insulin pen, if I'm in an inpatient setting, I've got a lot of opportunities that they could just give it to themselves.
Correct.
So those are really good teaching moments that sometimes we're just so into that normal flow, I just give, I do. Let them practice.
Exactly.
And those things really, they set the stage for the patient to feel comfortable being honest about what they don't know. And you get that immediate feedback right then and there that, hey, I have to explain this differently, or I did a good job and I can move on to my next patient.
Well, we doctors aren't specialists in everything. For example, my computer goes bad. I'll spend 3-4 hours trying to fix what's there. My son's into computers. He's a programmer and a technician, and I call him up and I say, what's good? He says, hit this button, and hit this button. After 3 hours of me trying to get that fixed, he did it in a matter of 2 minutes. So I understood, but he still didn't want to explain it to me. It's like they're secret or something. I don't understand that. Well, med speak is no good. You're talking about something like, you have an umbilical hernia, Mrs. Jones. She says, okay, what's that? Is that a new dance? No, it's a belly button hernia. And that would be, they'd understand it. It's a bulge of something outside your abdomen, shouldn't be there, and it's in your belly button area. So she would understand that. Okay, anything else you want to add to this? Do we have any other recommendations coming from you, the expert?
I have a few, some simple ones.
Shoot.
One, if this really resonates with you, something you're passionate about, there are ways to get involved and to learn more. Using TeachBack, using best practices around health literacy, they seem simple when I'm saying them, but they are a skill, and it takes practice to change the culture. So I recommend going to healthliteracycouncilde.org. That's the Health Literacy Council of Delaware. We have our own website. I'm on a subcommittee. Get involved. We have some subcommittees working on getting this information out there, helping providers, helping the healthcare team be more adept at mitigating these barriers for patients. And there's also resources there to maybe do some training or get some education on what you can do differently or how you can implement these things in your practice. That's number one. And number two, the one thing I would say is in a world where we all have a lot of competing priorities, it's easy not to see this. It's not right in front of your face every day. It's easy to forget. And it's easy to kind of get into this mindset that I just don't have time. And I hear it. But although it may take you a couple extra minutes on the front end, it's really going to, one, save you time on the back end, less patients calling back because they didn't know what to do, less portal messages if you have that at your organization because they didn't understand the instructions. And two, less patient harm, more patients going home and staying home and being able to take care of themselves, and more informed consent. So at the end of the day, maybe you don't see it as much, but I think we can all recognize that the importance is there.
I fully understand what you say and appreciate it. I'm sure the Medical Society can some way help you and your ideas get put out there, and hopefully we have more healthcare providers interested in learning how to speak down to the patient, avoid med speak. I'd like to talk some more with Amanda Joie on this subject, but we're going to take a short break right now, and we'll be back in a minute. Thank you.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
We're back from our break here with Amanda Joie, who's a specialist in educating people. Let me ask you this, Amanda. What class of people or what type of person is most vulnerable to misunderstanding, and are they easily reachable? Are they easily able to be gotten educated on their conditions?
Good question. Really, low health literacy can impact anyone. Statistically speaking, you're going to see higher levels of basic or below basic health literacy in the populations that are already vulnerable or more susceptible to have poor health outcomes. It is a social determinant of health. So when I'm talking about vulnerable populations, I'm talking about people who English is a second language, so native Spanish speakers, people with disabilities, older adults as well. In addition to that, people with lower socioeconomic statuses are often more likely to have basic or below basic health literacy. So these are all predictors to give you an idea of who might be more affected. But I think while that might give you an idea of how this impacts people who are already vulnerable to poor health outcomes, it's also really important to note that you can't really make assumptions because health literacy is not a static state. So when I say that it's not a static state, I mean that it's always changing for every single person. Today, right now, if you wanted to talk to me about my health, I'm having a great day, right? I could easily probably understand. I'd be one of your people who have high health literacy. But if tomorrow I was in an accident with my family and I was in the emergency department and the care providers there talked to me the way they would normally talk to another nurse, the odds that I'm going to be able to really process that information are going to be really different because my status has changed, right?
Okay,
Why?
correct,
Yeah, because I might have anxiety, I might be scared.
It's your family.
Yeah, right? When it comes to my family, my thought process changes. It's totally different when it's a patient for someone I know and love. If you give me a bad diagnosis, right, sometimes, like if someone told me I had cancer, I might just be so focused on the fact that I wasn't expecting that or how scary that is, that everything you say from that moment on, it's lost. And it doesn't matter that I have a master's degree. It doesn't matter that I work in healthcare. I'm a nurse, right? Everything changes in that moment. And so we can't really make assumptions, and that's why I hear a lot of people ask me, well, how do I know what someone's health literacy status is? It doesn't really matter. Because if we treat everyone and just with this assumption that everyone needs us to speak to them in a way that most people can understand, then we have a better opportunity of reaching more people. So what I tell people to do is use Health Literacy Universal Precautions. When you're scared, it's really hard to even hear what's happening in that room.
Fully understand.
And so if you don't take that time to use plain language, the opportunity. I mean, it's just not going to happen. And that's why, I often don't tell people I'm a nurse, because the way they speak to me, maybe that'll work in some circumstances, but it will never work for my husband, who is very much educated, but he does not work in healthcare. I mean, I had a complicated pregnancy, and I think after every single visit, my husband would look at me and be like, was I supposed to know what was going on? Am I supposed to remember anything? What am I supposed to do? Is everything okay? Are you okay? Is the baby okay? I would have to take the time to explain it to him in a totally different way.
Sure.
To make sure he knew what was going on. Because everyone knew me. I work where my baby was cared for. Not only do they know me, I cover those areas. They know me as someone that they go to for help. So they were like, oh, she knows this stuff. She helped us make the education on this thing. He didn't. Right? And also when it comes to your own baby and you're feeling anxious, I'm forgetting all the things we made. Suddenly I don't remember the whole book we wrote, right? You have these emotions that really impact the way you are able to receive the information, even information you already know. Wow. It just totally changes the way your mind is working.
I can understand that personally.
So assumptions are really the biggest thing we have to just pull out of factors. It doesn't matter what degree they have. It doesn't matter where they work, what they do. We can just go into it with that basic universal approach. We're giving people more of an opportunity. And in the same way, we can't assume what language people prefer. We have to ask people when it comes to that. So, I have a lot of my own patient encounters or my own family encounters. That's why I do this. I'm very passionate about the work because of
I can tell.
Where I came from, how I grew up. And so I grew up in a family where I would say that my parents and my grandparents probably have lower health literacy levels, and there's nothing wrong with that. Again, has nothing to do with intelligence. I think my parents are both very intelligent. Had they had half the opportunities I had, I think their circumstances would be very different today. But having grandparents where English is a second language, and parents who, when I was a kid, I was the smart one, always looking to me. Pretty quickly at a young age, it was recognized that I understood what the doctor said better than maybe my parents did, or I understood all that information that we got, the 20 pages from the pharmacy. I could read that maybe at 8 and pull out more information than they were able to understand. And so that was a burden on me, not one my parents gave to me lightly, but at the end of the day, someone needed to be able to figure it out. And when we don't explain things for our patients in a way that they can understand, it falls on someone or it falls on no one, and then the patient gets hurt.
Interesting point you made. Can you overeducate a person? Like, for example, they go to the pharmacy and get 20 pages of all the harms that this drug that I just wrote them for a prescription, and they don't take the prescription because it scares them, the wits out of them. And, the majority of times, vast majority of times, nothing happens that's adverse regarding that medication. I get a little angry about that because sometimes you can overeducate them and they don't want to take the medication because it's going to cause me to die when it doesn't.
Yeah. So I think you're hitting on a really good point about information overload. Mm-hmm. And so, yes, we can give patients too much information at one time, and then it makes it hard for them to really understand the key points. Prioritizing information with our patients is very important. Not to keep them in the dark about anything, but you always want to kind of start with the most important things. Have in your mind, hey, these are the really big important things that they need to know and need to do between now and their next healthcare encounter. And make sure that they are able to explain that back so you're sure that you're clear. When we're talking about side effects and these long things from the pharmacy, the problem with them is they're just so overcomplicated that it is hard to understand that this only happens to 1% of people, because I have to read through 50 pages of, such elevated language that even I, as a healthcare provider, I have looked at these things sometimes and I'm like, what is happening here? I'm like, I don't even know. My husband just got a new inhaler, and I had never seen this type before. It must be something new. And I was like, I had to go on my work computer and look it up in our work formulary because I have no idea what this is saying right now, and I've never seen this type of inhaler before. I am a nurse. I have asthma. I've used inhalers my entire life. Okay. And so it just kind of goes to show that when we overcomplicate that information, people might be hesitant to do something because they don't totally understand what the ramifications are of, 1, not taking it, and 2, what the side effects really mean and how those will impact them, or 3, what to do if they have the side effect, because we're not going to ignore them. If something happens to them, we are going to help them. So prioritizing the information and making sure that the information we prioritize is understandable, because yes, when patients are not informed, sometimes they don't make the best choices for their health. Had they had the right information, their choices might be different, but you can't really have informed consent if you don't actually get informed. And being informed means understanding.
Exactly. I fully agree with you.
So patient education is important to a lot of people and in a lot of places and in a lot of spaces. So there are requirements and there are regulations from, multiple different bodies, Joint Commission being a big one. And there are a lot of recommendations from a lot of different organizations, including, AHRQ we talked about earlier. But despite the fact that the things we've talked about today, those things that we can put into practice, those aren't new. We've known that these are recommended practices for like 10 to 15 years at this point. And so we recommend it, but there's really no follow-up. And because of that, it's kind of lost in the sauce. There's so many other things that you need to do. But yes, regulatory-wise, we are required to teach patients about what the reason they're taking their medicines are. Can you imagine having 20 medicines and not knowing what any of them are for? Exactly. That's the reality for most of the patients I cared for. They would be like, I don't know, I take a blue one, a purple one, a pink one.
That's exactly right.
And I'm like, oh man, I got a lot of teaching to do. So then if they didn't take one, they don't understand what that means. Because they don't even know what it's for.
So many times I get the question, what are you taking? A little blue pill. I think it has a line in it. It's got some numbers on it. I said, well, what's it for? I think it's for my blood pressure. Well, you'll have to bring it in and let me take a look at it because I have no clue which blue pill it is because it's generic and, it comes from another company, etc. So it is very, very confusing to patients. So I think it's a great idea to talk to them and tell them what it's about, what it's for, and if they have any questions, feel free to call you should say. Call me anytime if you have a problem.
Yeah, being open, that also establishes trust with the patient. And people really, there is, especially in our vulnerable populations, there is this negative connotation. Like, no one wants to feel like made to look stupid. And I think that we put patients in this position where they don't want to be honest when they don't understand. They want to know. Trust me. They want to know, but instead of going to you because they don't feel comfortable, they go to Facebook. They go to Google. Okay? And some stuff out there is reliable, but they might not know how to differentiate what's truthful, what's honest, what's research-based, and what's not. And when we don't establish that trusting relationship where they feel like they can say, hey, I heard this thing, or I read this thing, is, here, what does that mean? Is that true? Well, then they're just going to go ahead and listen to their mother's brother who knew somebody who said, you don't take that medicine, aspirin, because you can't take aspirin because aspirin is going to make you have a stroke, right? And these are the kinds of things, people trust them, so they believe them. They don't trust us because we haven't historically been trustworthy, and so we have to bridge that gap and build that foundation of trust first and foremost. And if we just keep kind of dictating and lecturing to patients without actually taking into perspective how they understand that information, we're never really going to change that. It's just going to be a constant cycle.
Understand.
Yeah. Think about it. When you're in a class or you take a webinar, you were there for an hour, if I had a test on it right afterwards, I certainly would not be able to tell you every single thing I learned in that 1 hour session. No, that's too much information.
No photographic memory?
No. Okay. And patients are the same way. They only remember 40 to 80% of the information they get in an encounter, half of which they remember wrong. So they only come away with 25% of the information they get in an encounter statistically.
How many questions do you get on people who look on Google because of this mark on their arm and come into me and say, I think I have cancer? Because a pimple, if you go to Google, it's cancer until proven otherwise. Do you get a lot of that information? Does your family even, if that becomes
Yeah. I think a lot of people, there's two things they do. They either look at it and they say, oh, this is really, really bad, when it's something that isn't, which I mostly kind of prefer. Or other people who are like, well, I can just do this thing where I put this baking soda and vinegar on it and it'll go away, or it's fine because my sister had one that looked like this and it was okay. Or my mom always says, oh, well, I don't really, I don't want to bother them.
I hear that a
So
lot.
I just asked, like someone random, not even me, the healthcare person. I just asked a friend, and she said one time her leg was hurting. I'm like, Mom, you've had blood clots before. If your leg is bothering you, it's really something
That should be looked
that
at.
should be looked at. Is there swelling? Those are the kinds of questions they don't know to ask. How would they know? It's not for them to know. It's for us to know. And when we don't give them information in a way they can understand, we just kind of set them up for failure.
This has been a real pleasure speaking to you today, Amanda. I'm glad you brought this up to us, and I'm glad, and if there's any way we can be helpful to you, providing this information to the doctors and patient care individuals, so that they can really speak to the patient and let the patient fully understand what's going on, so they don't mess up and they don't get bad outcomes. I appreciate you coming. If there's any way we can be of help to you in promoting this or fostering this attitude, we would love to do so. So feel free to ask the medical side if we can give you any help in this regard. This alone may be helpful, this podcast. We have a lot of people listening, so I hope that they take this to heart. And we have a lot of providers listening, and we hope they do too. This is Dr. Nick Biasotto here with Amanda Joie, and we appreciate her input, and we'll talk to you later. Have a good day.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitten. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.